Good morning, everyone, and thank you so much for joining. My name is Alexandra, and it is a blessing and a pleasure to have you. We are going to be doing NCLEX review, and we are going to be covering renal today. So we are on page 200 of your study guide. So to get started, the basics. Make sure you know that the functional unit of the kidney is called the nephron. So that is the smallest cell in the kidney that performs the work of the kidney. Also, make sure you know that to reabsorb means the kidneys are keeping something in the body. So, for example, if the kidneys are reabsorbing sodium, they are keeping sodium in. If the kidneys excrete something, they are removing it from the body. So if the kidneys are excreting potassium, the potassium is leaving the body. The many functions of the kidney include maintaining acid-base balance, controlling fluid and electrolyte balance, secreting hormones like renin, which help regulate blood pressure, secreting hormones like erythropoietin to stimulate the bone marrow to produce red blood cells, and synthesizing vitamin D for calcium absorption. So some things that I would keep in mind, I would memorize that renin is a hormone that increases blood pressure. Erythropoietin is a hormone that stimulates the bone marrow to create red blood cells. And some other important hormones that you're going to hear about, but that we will learn more in Module 8, include antidiuretic hormone and aldosterone. Antidiuretic hormone is basically going to increase blood pressure. So here we have two hormones we've learned about, renin and antidiuretic hormone. These increase blood pressure. Aldosterone is another hormone that is going to increase blood pressure. So for now, good morning, everyone. Thank you so much. So for now, I would memorize that renin, antidiuretic hormone, and aldosterone. These three hormones increase the blood pressure. Next, we have some important labs that you need to be familiar and comfortable with. BUN, or blood urea nitrogen. A normal level, some people say 10 to 30, some people say 8 to 22. I learned 10 to 30 in nursing school, and some books say 8 to 22. So either of those are fine. So it measures how much urea is in your blood. Then you have creatinine. A normal creatinine is 0.5 to 1.5. So it is important to know that BUN and creatinine are kind of the most common labs used to assess kidney function. So when you want to quickly see how the kidneys are doing, usually the healthcare provider will order a BUN and creatinine. I want you to know that creatinine is more sensitive to kidney function. So the most reliable indicator for kidney function in terms of a lab level is creatinine, serum creatinine. Okay, give me one moment. I believe a student is having trouble getting on. Give me one moment. It's the same Zoom link every week. So in that same document I send you that always has the recordings, at the top where it says Zoom link, it's the same Zoom link every week. It will not change. Okay. BUN creatinine ratio, this is just taking the BUN and dividing it by the creatinine. And that's just another way that healthcare providers monitor kidney function. But remember, the two most common labs for kidney function are BUN and the serum creatinine. And which one is more sensitive to kidney function? Serum creatinine. Why? Because the BUN can be affected by other conditions. For example, eating too much protein or not enough protein can affect the BUN. But creatinine, if serum creatinine is elevated, that is because there's a problem with the kidneys. Then we have glomerular filtration rate, and this is a measure of how well the kidneys are filtering waste out of the body. In younger adults, they have a glomerular filtration rate, or a GFR, of 125 milliliters per minute. So that means every minute their kidneys are able to filter out 125 mLs of blood. However, it's important to keep in mind that GFR naturally decreases with age. So when we are a young adult, our GFRs should be about 125 mLs per minute. But as we get to age 65, it will naturally decrease to 65 milliliters per minute. Urinalysis. This is when we obtain a sample of urine and analyze what's in it. For example, you can analyze if there's sugar in the urine, if there's bacteria, white blood cells, red blood cells. So urinalysis is really kind of like the first step in analyzing kidney function using the urine. So again, if you want to see if the patient has a UTI, the healthcare provider will order a urinalysis to see if it has white blood cells and nitrites and leukocyte esterase. Urinalysis will tell you if there's ketones in the urine, if there's glucose in the urine, if there's blood in the urine. So urinalysis is really analyzing the urine to see if there's certain components in the urine. 24-hour urine collection, you can study that for homework, but please do study that. Specific gravity is how concentrated is the urine, okay? So let me show you a picture. Okay, so urine specific gravity, it tells you how concentrated is the urine. So memorize that a normal urine specific gravity is 1010 to 1030. So 1.010 to 1.030, 1010 to 1030. Okay, so again, urine specific gravity tells you how concentrated the urine is. So the more concentrated the urine is, the higher the urine specific gravity. So the first cup, this urine is very diluted, so it's going to have a very low urine specific gravity. So that's going to be probably less than 1010, right? And then something normal like the second cup and the third cup of urine, these are more going to be within the range of 1010 to 1030, right? With this one maybe being more 1010 and this one being more 1030. Now these last two cups of urine are too concentrated, so these are going to be higher than 1030, right? So what do you need to know? Urine specific gravity is how concentrated is the urine. The normal level, 1010 to 1030, and the lighter and more diluted, the lower the urine specific gravity. The more concentrated, the higher the urine specific gravity. Some other pictures I want to show you is a picture of the renal system. So the renal system is comprised of two kidneys, the ureters. The ureters take the urine from the kidney and bring it to the bladder. And from the bladder, the urine will drain from the urethra. Okay. Here is a close-up of the kidneys. So as you can see, the kidneys are very vascular. They have a lot of blood vessels. The job of the kidneys is to filter out waste from the blood. So obviously, it needs a high amount of access to the blood, so it has a high amount of blood vessels. So you can say that the kidneys are very vascular. So that also lets you know that when there is not enough blood flow to the kidneys, that's also going to affect their ability to properly carry out their function, right? So if there's not enough blood flow, for example, if you're dehydrated, if you don't drink enough water, your fluid volume will be low. And that means that the kidneys will receive a lower amount of perfusion, right? And that means the kidneys will make less urine. So does that make sense why when we're dehydrated, we don't make enough urine? When we're dehydrated, our fluid volume is low. The kidneys receive less perfusion. So you're giving the kidneys less blood to work with, and that's why they make less urine. And also, the more dehydrated we become, the more concentrated our urine is. So that makes sense with why when you don't drink water all morning and you finally go urinate in the afternoon, your urine is very concentrated, right? And this is a further view of the nephron, the functional unit of the kidney. And so that's why when we say nephrology, nephritis, pyelonephritis, when we say NEPH, neph or nephro, we mean renal. Okay. All right, let's go back to the lab levels we were talking about. Urine culture and sensitivity testing. So this is very important. So usually, and let me put 2 stars so you can see. So usually when we have urinalysis, we're going to have urine culture and sensitivity. So remember, I told you that urinalysis is really just analyzing the urine for what's in it, right? So what are we looking for in the urine in a urinalysis? We're looking for white blood cells, red blood cells, protein, glucose, ketones, leukocyte esterase, nitrites, right? And so let's say if the urinalysis had high white blood cells and high leukocyte esterase and high nitrites, what are we suspecting? Let me know in the chat. What are we suspecting if a urinalysis sample has high white blood cells, it has high leukocyte esterase, and high nitrites? We're suspecting that the patient has a UTI, right? But now we need to know, well, what is the organism potentially causing this UTI? And that's where we would do a urine culture and sensitivity. So the culture is going to tell you what is growing, what is the name of the microorganism that's growing, if there even is one, right? Um, it's going to tell you the name of the bacteria that's growing. And then the sensitivity part is going to tell you what antibiotics will kill that bacteria or what is it resistant to. Creatinine clearance test you can read for homework. So remember, you have to read your study guide for homework. Some other tests, and someone keeps drawing on the screen. If let's see something here. Give me one moment. All right, one moment. All right. So KUB, a KUB, it stands for kidneys, ureters, and bladder. It's an X-ray of the urinary system to detect kidney stones. A bladder ultrasonography or a bladder scan. This is a non-invasive way to measure how much urine is in the bladder. Next up is intravenous urography. So this is an X-ray procedure in which IV injection of contrast dye is used to visualize and identify abnormalities in the renal system. Okay, so we're really focusing on what you need to know for NCLEX. Okay, so these last two, I do want you to study for NCLEX, cystoscopy and biopsy of the bladder and renal biopsy. So cystoscopy, it basically, anytime you see a word ends with oscopy, we're using a camera to view something. So let's look at a picture to help us tie it together. So this is a picture of a cystoscopy. And so a cystoscopy is the healthcare provider is using a cystoscope to view inside the bladder, and if they need to or make the clinical judgment to do so, they can obtain a bladder biopsy. So this is something maybe that they would do to rule out bladder cancer or to visualize if there's some type of blockage or stone or irritation or inflammation that requires further testing with the use of a biopsy. Okay, so make sure you know the position for cystoscopy is a lithotomy. The major complications you're worried about are hemorrhage, urinary retention, and infection. Some things that you need to notify the healthcare provider of immediately: if the patient has bright red blood, if they cannot void, or if they have a temperature greater than 100.4. It is normal after cystoscopy for their urine to be pink or tea colored, like the color of water in a tea bag kind of thing. If they have difficulty peeing or they're peeing a lot, that is normal afterwards. What you are concerned about is bright red blood, if they can't void at all, or if they have a fever. Okay. Next up is a renal biopsy. Renal biopsy is utilizing some type of imaging like ultrasound to obtain a biopsy of the kidney. So what is important here is before a renal biopsy, they need to do baseline coagulation studies. Okay. So before a renal biopsy, we need baseline coagulation studies because the risk of bleeding is high. Okay. Afterwards, our number one priority is to monitor blood pressure because the risk of bleeding is high. Remember, the kidneys are very vascular, they have large access to blood vessels. Their job is to filter out blood, so they're constantly receiving blood. Therefore, if we're sticking a needle inside of the kidney to obtain a piece of tissue, the risk of bleeding is high. Okay, so make sure you know renal biopsy. A priority before is baseline coagulation labs. A priority afterward is to monitor the blood pressure because if they were bleeding, the blood pressure would drop. We provide pressure to the biopsy site for 30 minutes. All right. Now we're going to talk about different ways to void. So here are the different ways to void. You can void the natural way, which is through your urethral meatus. You can use intermittent urinary catheterization, indwelling urinary catheterization, suprapubic catheter, nephrostomy tubes, or ileal conduits. So let's take a look. So someone who was born male, they can use the urethral meatus through here. So their kidneys will make the urine and it will drain from the ureter into the bladder, and from the bladder it will drain into the urethra, and the urine will come out through the urethral meatus. An individual born female, it will come out of here, okay? The urethral meatus. So you have the clitoris on the top, the urethral meatus, which is in the middle, and the vagina and the anus. So a female would pee through here. So those are the natural ways to urinate. Now, when an individual is having issues urinating, or the healthcare provider believes they need assistance voiding, they can order an indwelling Foley catheter. So this can be intermittent or this can be indwelling. Intermittent is what we call in and out, where we insert the urinary catheter in, we drain the urine out, and then we take it out. Intermittent urinary catheterization is very bad because it has a high risk of UTI, especially the more often we do it. So very rarely are you going to see that they're ordering intermittent urinary catheterization, like putting the catheter in and then taking it out, and then 2 hours later getting a new catheter, putting it in and taking it out. Very rarely are they going to do that because the risk of UTI is very high. Then you have indwelling urinary catheterization where you're using a Foley, and this is going to stay here for hours to days. This is also bad because the risk of UTI is high. And the difference between intermittent and indwelling is intermittent, you don't have the balloon. Because intermittent urinary catheterization, it's in and out, right? But indwelling, it's going to be dwelling in the bladder for some time. So we inflate a balloon, which is going to help keep the catheter in place. The urine will drain, and there's a hole at the top of the tip here. And the urine will drain into the tip and out into a bag. So this can only stay in place for 30 days maximum, and then we will need to change it. Will a patient need it for 30 days? Not all the time. Sometimes they just need it for surgery. Sometimes they just need it while a wound heals. Sometimes they just need it because they're going into labor, and after the baby comes out, the doctor will order it to be discontinued, right? So just keeping in mind that anytime we deviate away from the natural way to do something, we're going to cause complications. So when we are using a urinary catheter for our patient, whether it's intermittent, which is in and out, or indwelling, which is it's going to stay for hours to days, the risk of UTI is always there. Remember, inserting a urinary catheter should be sterile because we do not want to cause catheter-associated UTI. Also, we have suprapubic catheter. So what's the difference? An indwelling catheter, you went in through the urethra meatus, right? So if it was a male for urinary catheterization, you're going through here. If it's a female, you're going through here, right? But suprapubic catheter, you're going through the pubic area. So straight through the skin, straight into the bladder. It has a balloon to help it stay in place. Okay, so the healthcare provider would insert this surgically. So when would this occur? Maybe they have trauma to the urethra or to the perineal area. Maybe they have some type of tumor that is obstructing the bladder neck or the urethra, or some type of disease process is affecting the patient's ability to get urine out of the bladder and through the urethra. So this would be an indication for the insertion of a suprapubic catheter. Okay, one of the most devastating cases I've ever seen. I was in nursing school, and I believe we were doing mental health clinicals, and a young girl, she had a suprapubic catheter in that pretty much was going to stay in for the rest of her life. And obviously they changed this. I believe it's every 30 days they change the suprapubic catheter. And again, inserting it is sterile technique, cleaning it and changing it is sterile technique. Now, why did she have it in? And she was young, like 5 or 6 or 7 years old, because someone raped her when she was a baby. And they raped her so bad that all of her perineal area was permanently damaged. So she could never pee normal again. So that is one of the most devastating stories I've ever heard in my life. Okay. So remember, a healthcare provider is going to be the one to surgically insert this the first time. And then nurses, we are able to use sterile technique and use this port to deflate the balloon. So we insert a syringe and we pull back. The fluid that's used to fill up the balloon will leave, okay? And then the balloon will be deflated and we can remove this catheter, and then we can insert a clean one in using sterile technique after we clean the insertion site. And we insert a new suprapubic catheter, and then using a new syringe with new solution, we inflate this balloon and it will stay in place. And there are dressings we can use to cover this. It already comes pre-cut and we fit it around this, and we use skin tape to tape this. And we would want to keep this insertion area clean at all times when we're giving the patient a bath. We would use a fresh towel or fresh washcloth to clean this area, because again, we don't want to give bacteria direct access to the bladder, because again, anytime we're using a catheter to get urine out of the body, the risk of infection is increased. And from there, we can use something like a leg bag. Nephrostomy tubes. So this is a percutaneous nephrostomy tube. So this is absolutely surgically inserted. And nurses, we don't change the tubes. All we do is keep the insertion site clean. We monitor for discharge and signs of infection. And so we're monitoring for pus around the insertion site. And we're monitoring to see if the urine is cloudy or has a foul odor. Also, we're monitoring for any bleeding. So nephrostomy tube, so nephro, kidney, ostomy, a surgical, hole made. So the surgeon made a hole in the kidney and inserted a tube inside the kidney that will directly drain the urine. So as the kidney makes the urine, it drains into the bag. So the kidneys aren't draining into the ureters and then going into the bladder to then exit the body. The urine is draining here. So your number one issue with nephrostomy tubes is infection, because again, this is what would cause something called pyelonephritis, which is kind of like a UTI but worse. Okay? So keeping that in mind, again, with all of these devices, urinary catheters, suprapubic catheters, nephrostomy tubes, your number one issue here is that your patient is at increased risk for infection. An ileal conduit. So now this one is not as bad as this one doesn't have the same risk of causing infection like the others do. So an ileal conduit is where something is wrong with the bladder, and unfortunately they have either had to remove it or disconnect it from the renal system. So the kidneys are still going to make urine. The urine is going to still drain in the ureters, but instead of the ureters being connected to the urinary bladder, the surgeon is going to make a bladder. So ileal, it sounds like the ileus, right? Which is the last part of the small intestine. So the surgeon is going to take a piece of intestine, which is probably from the ileus, the small intestine, and they're going to it's going to make a pouch, and that is going to be the new bladder. And he's going to make a stoma, which is a hole or opening outside of the body. Okay, so it's not a colostomy. A colostomy is for poop. An ileal conduit or will form a urostomy, okay, which is a stoma meant to allow the drainage of urine outside of the body. Okay, so this would be a urostomy. This is a urostomy bag. So you're not so concerned about infection here. You're still going to wash your hands. You're still going to put on gloves. You would use clean technique to change this device and clean the area around it. However, your concern is skin integrity. Okay? Urine on the skin will break it down. And we don't want a breakdown of skin in that area, because broken skin can introduce infection, bacteria, and lead to more breakdown of the skin. So we're concerned about skin integrity here. There's also a technique or procedure called continuous bladder irrigation. So if the patient has had some type of renal procedure that is going to cause blood clots, those blood clots are going to block the bladder neck, and it's going to lead to urine retention, and urine can't get out of the bladder. So if for some reason there would be a blockage in the bladder for the post-op period or for some time after, the doctor may choose to use continuous bladder irrigation. And what's going on here is you're going to have a three-way catheter. So these are the three ways of the catheter. You have irrigation solution going in. Why? Because whatever procedure the patient has gone under, or whatever disease process the patient is dealing with, it requires that the irrigation solution wash the bladder so that blood clots and urine, so that blood clots don't get stuck. So irrigation is when we put fluid in and allow it to drain back out, right? Irrigation, you put it in and you allow it to come back out. So for whatever reason, this patient's bladder needs to be irrigated. So this is the one way of the three-way Foley is to allow irrigation fluid to come in. The second way of a three-way Foley is to allow the irrigation fluid and urine to drain out into the drainage bag. So not only is irrigation solution going to escape, urine is going to escape, blood and blood clots is going to escape as well. And then the third way of the three-way Foley is the port that we use to inflate the balloon. So the solution is injected and will inflate the balloon to keep the catheter in place. When it's time to discontinue the continuous bladder irrigation, there will be a clamp here. We would clamp this shut, and then we would deflate the balloon, and the balloon would be deflated by aspirating, by connecting the syringe and pulling back. The solution that was making the balloon be inflated will be removed in the syringe, and then we can pull this out. When you're calculating output for this patient, you have to consider how much fluid you put in. So if this was a 3,000 milliliter bag and only 1,000 was left in, you would say for input 2,000 went in, right? And you're going to expect at least 2,000 to come back, right? So if 2,000 went in and 2,000 came out, your patient didn't urinate, because whatever you put in is exactly what came out. However, if you put 2,000 in and 2,400 came out, so that 2,000 is the irrigation solution and the 400 is how much your patient voided. Give me one moment. All right, so that is continuous bladder irrigation. All right, guys, so let's take a 5 minute break. And when we come back, we will begin talking about acute kidney injury and chronic kidney disease. Okay, so the 5 stages of chronic kidney disease. So remember, a normal glomerular filtration rate, like in a young adult, is like 125 milliliters per minute. And remember, as we age, it naturally decreases. However, an individual with chronic kidney disease, they're going to have reduced glomerular filtration rate. So, to identify the extent of kidney damage, chronic kidney disease is classified into multiple stages, right? Stage 1 through 5. These 5 stages are determined by measuring the patient's glomerular filtration rate. So the glomerular filtration rate number indicates how much kidney function the patient has. As chronic kidney disease worsens, the GFR decreases. So remember, normal GFR for an adult should be 125 mLs. So stage 1, the GFR is greater than 90 still. Stage 2, it's 60 to 89, so it's decreased. Stage 3A, 59 to 45. Stage 3B, 44 to 30. Stage 4, 15 to 29. And stage 5, less than 15, right? So you mean to tell me in a healthy adult, their kidneys can filter out 125 milliliters of blood every minute, but by the time an individual gets to chronic kidney disease stage 5, their kidneys can filter out only less than 15 milliliters of blood a minute. And that is why it's called end stage renal disease. Okay. So this is another description. So you can, use any picture that you would like from this recording to study. Um, And then this kind of lets you know what you should do. So as you're watching the recording, I want you to read this. I want you to read this when you go back and watch the recording. But it's very sad because we do not want our patients to get to this point. Okay? So now let's look at the study guide. So acute kidney injury is the rapid loss of kidney function from renal cell damage. So the issue with acute kidney injury is the tissues of the kidneys have become damaged. Some condition that the body is being subjected to is not ideal for renal function and the survival of the renal cells. And remember, acute, this is rapid, versus chronic kidney disease is like a progressive, over time, a gradual, right? But acute kidney injury, this is a rapid loss of kidney function. We can get the kidney function back if we reverse the cause. So when we're talking about the causes of acute kidney injury, we say pre-renal, intrarenal, and post-renal. So let's look at this picture. Okay, pre-renal, intrarenal, and post-renal. So a pre-renal cause of acute kidney injury occurred before the kidneys. An intrarenal cause of acute kidney injury is because of the kidneys. The problem is within the kidneys, and this has caused the renal cells to be damaged. Post-renal, it's something after the kidneys. So pre-renal, the heart is highlighted here. Why? Because fluid volume has a major impact on renal perfusion. Okay, so let's say, for example, the patient has dehydration, severe dehydration. This is an 80-year-old male who lives alone, and he fell at home, and he's been on the floor for 3 days and has not drank, has not eaten. And his daughter comes to visit him and finds him on the floor and calls 911. We bring him to the hospital. Thank God he's alive, right? And we check his blood pressure. It's 82/40. His blood pressure is low is because he hasn't been drinking water. His blood pressure is low because his fluid volume is low, right? And we check his creatinine. His creatinine is 4, right? A normal creatinine is 0.5 to 1.5, but his creatinine is 4. His creatinine is elevated because his kidneys have been damaged as a result of the dehydration. So the heart is highlighted here because you need proper cardiac output to make proper urine output. Why? You need proper cardiac output so that the kidneys can get properly perfused. If we don't have enough fluid volume, the blood pressure will be low. And if the blood pressure is low, the kidneys don't get perfused properly. And if the kidneys don't get perfused properly, the kidneys won't make enough urine. And not only that, but if the kidneys don't get perfused properly, you're literally saying that the kidneys are not getting enough oxygen. So how can the tissues of the kidneys survive if they're not getting enough oxygen, right? So always think of that relationship. I need proper cardiac output to make proper urine output. If I have a low blood pressure, the kidneys do not get perfused adequately. And if the tissues do not get perfused adequately, the tissues become hypoxic and the tissues of the kidney begin to become injured and they can die. Okay, so one of the major causes of pre-renal causes of acute kidney injury is caused by intravascular volume depletion. For example, what can cause intravascular volume depletion? Dehydration, hemorrhage. That is one of the major causes of shock, hemorrhage, right? Infection, because infection can lead to septic shock, and septic shock would drop the blood pressure and reduce renal perfusion. Okay. Another major pre-renal cause is hypertension. Hypertension, remember I told you hypertension causes vasoconstriction of the renal arteries, and that is also going to reduce blood flow. Then you have intrarenal causes of acute kidney injury like tubular necrosis, prolonged prerenal ischemia. So when the fluid volume in the body is so low and the kidneys aren't getting enough oxygen, the cells of the kidney become hypoxic, and this, if not reversed, can lead to prolonged prerenal ischemia. Or if there's like a stone in the kidney and it's obstructing, it's an obstruction, that can also be a cause of intrarenal AKI. And then post-renal, this is like obstruction with a stone or bladder cancer. Okay. All right, for homework, review the phases of acute kidney injury. Interventions, you can read that for homework. If there was something that stood out for NCLEX, I would tell you. But for NCLEX, it's more so understanding the relationship between cardiac output and urine output. You need proper cardiac output so you can have adequate urine output. So that means you need to have a stable blood pressure. To have a stable blood pressure, you have to have proper fluid volume. So if your patient is dehydrated, we give them IV fluids so that we can increase their fluid volume, so they can have a proper blood pressure, so they can have a proper cardiac output, so the kidneys can get properly perfused, so the kidneys can make a normal amount of urine. So that is why when a patient is very unstable, we usually, like in ICU, almost all of the patients in ICU have a Foley catheter. Why? So we can measure their urine output. So that if they're making 30 mLs of urine an hour, that means they have proper urine output. And if they have proper urine output, there is a high chance they have proper cardiac output. But let's say we're taking care of a septic patient with a low blood pressure and we put the Foley in and they're not making any urine. That means they have poor urine output because of poor cardiac output, because the blood pressure's low, because they need more fluids. Tell me in the chat if that makes sense. Okay? If you can understand that, you will be good for NCLEX. All right? The best action for acute kidney injury is to identify the cause, reverse it, reverse the AKI. And this usually involves IV fluids and Lasix, but every situation is different. So that's why when you come across the situation, you will work with the healthcare provider. But again, usually you're dealing with a situation where blood pressure is low, and that usually involves IV fluids. Or if we're dealing, let's say, for example, with high blood pressure and that's damaging the kidneys, then we're going to focus on treating, reducing the high blood pressure with medication. All right, chronic kidney disease. Chronic kidney disease, a slow, progressive, irreversible loss of kidney function. So this is a gradual loss of kidney function. Acute kidney injury, it happens quickly. We can treat it quickly. Chronic kidney disease, it happens over time and we cannot reverse it. So there's some things that you need to know for your NCLEX. So on page 203, where it says assessment, please study that for homework. We're going to go over some of the important ones, but please, 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 you study that for homework. So first up, let's go over this section where it says special problems in kidney disease. So you have to memorize these. And I'm not saying memorize the whole page, but memorize and more so understand why that chronic kidney disease causes these issues. And then it will help you to remember the treatment. Okay, first up, special problems in kidney disease. First up is activity intolerance and insomnia. Why? So I would memorize chronic kidney disease causes fatigue. Why do they have fatigue? Because they're anemic. Memorize that for NCLEX. Patients with chronic kidney disease, and then you put, so just put special problems in chronic kidney disease. Number one, fatigue because of anemia. Number two, anemia because the kidneys aren't making erythropoietin. I told you earlier, the kidneys release erythropoietin, and erythropoietin travels to the bone marrow and makes the bone marrow make red blood cells. But this patient's kidneys aren't working normally. So they're not making erythropoietin or making enough of it. So they're not making enough red blood cells. Okay? So special problems with chronic kidney disease, number one, fatigue because they're anemic. Number two, they are anemic because they don't make enough erythropoietin. So how do we treat it? We give them man-made erythropoietin. It's called epoietin alpha or there's also darbepoetin. We give them iron supplements. You give them blood transfusions if needed. Why iron? You need iron to make hemoglobin. And hemoglobin is what's going to carry the oxygen in the red blood cell. Okay? So special problems with chronic kidney disease, number one, fatigue because they're anemic. Number two, they're anemic because they don't make enough erythropoietin. How do you treat it? You give them man-made epoetin, epoetin alpha, darbepoetin. You give them iron so they can make hemoglobin. You give them blood transfusions as needed. Number two, they're at increased risk for GI bleed. Number three, they're at increased risk for GI bleed. Okay, so make sure you write this down. Patients with CKD should never take NSAIDs like aspirin. Okay, so patients with chronic kidney disease should never take NSAIDs like aspirin, ibuprofen, or naproxen because they damage the kidneys and they lead to GI bleed. Okay, so these are NCLEX essentials. You cannot escape these on NCLEX. You have to know them, you have to understand them well. Okay, so special problems in CKD, number one, fatigue because they're anemic. Number two, they're anemic because they don't make enough erythropoietin. So we give them man-made, we give them iron, blood transfusions as needed. They're at increased risk for GI bleed. To avoid that, we never give them aspirin. We never give them NSAIDs. Okay, so three major NSAIDs to know for NCLEX: aspirin, ibuprofen, and naproxen. Naturally, the kidneys get rid of NSAIDs. This patient's kidneys aren't working well. So we don't give them a medication that's going to stress out their kidneys. And also it leads to GI bleed. Number four, this is NCLEX. You have to know that chronic kidney disease leads to hyperkalemia. With chronic kidney disease, the kidneys lose their ability to remove what it needs to and keep what it needs to. And one of the components that the kidneys struggle with, besides protein, is potassium. So that's why a patient with chronic kidney disease is going to be on a low potassium diet. Okay. So medications that reduce potassium that may need to be used in a patient with chronic kidney disease: oral polystyrene sulfonate, Kxalate. So if you have a patient with chronic kidney disease and they have a high potassium and they're symptomatic or it's dangerously high, you can give Kxalate. If we don't have a lot of time where the patient is NPO, we will use IV regular insulin plus dextrose, where the insulin would open the door to the cell so the potassium can go inside the cell, and it would also take glucose with it, which is why we give the dextrose. Okay. Also, from your study guide, we can administer loop diuretics. Loop diuretics like furosemide, they would help to reduce the potassium level. Okay, so keep saying this to yourself. Special problems with CKD. Number one, fatigue because they're anemic. Number two, they're anemic because they don't make enough what? Erythropoietin. So how do we treat that? We give them man-made epoietin and DARB epoietin, iron supplements, blood transfusions. They're at risk for GI bleeds, so we don't give them NSAIDs. What are your three NSAIDs to know for NCLEX? Aspirin, ibuprofen, naproxen, because they would increase the burden on the kidneys and they cause GI bleed. Hyperkalemia, patients with CKD are at increased risk for high potassium. So, what kind of diet should they be on? Low potassium diet. What are some medications we can use to reduce potassium level? Polystyrene sulfonate, Kayexalate, regular insulin plus dextrose, and loop diuretics. Okay, the other thing we're going to add on to that, and this is going to take you studying and getting this in, is we want to avoid potassium sparing diuretics like spironolactone and triamterene. So NCLEX might try to trick you. So you want to focus on loop diuretics. Loop diuretics would drop the potassium and help the patient. Potassium sparing diuretics would probably lead to their death, okay? So keep that in mind. Next up is hypermagnesemia. So this is another issue that patients with chronic kidney disease face. The kidneys aren't able to get rid of magnesium. So loop diuretics would help with this, okay? Also avoid medications with magnesium, like a lot of antacids and laxatives and enema have magnesium. Have you ever heard of milk of magnesia? That white milky substance that we use like for stomach upset and as an antacid. So milk of magnesia, that has magnesium. So a patient with CKD is already at risk for high magnesium. We would want them to avoid that. Also, let me show you this picture. This glass bottle that you can get at Walgreens, like the magnesium citrate, like that's it's like a laxative, like you drink it and it really makes you go to the bathroom. um would we want our patient with CKD to get this from Walgreens over the counter? No, because they're already at risk for high magnesium. So we're forming a picture of the electrolyte imbalances a patient with CKD is at risk for, right? So there's no way around it. So far we have, so electrolyte imbalance of CKD. So number one is high potassium. Number two is high magnesium. Okay, number three is high phosphorus. Okay, so let me show you. So hyperphosphatemia. So for this, we give sevelamer, Renvela. This is what is called a phosphate binder. Okay. And then also keeping in mind that phosphorus and calcium have an inverse relationship. So when phosphorus increases, calcium is going to decrease. Okay. So the only low one in the party is calcium. So just remember chronic kidney disease, potassium, mag, and phosphorus are high, and then phosphorus and calcium have an inverse relationship, and so it's low. Okay. And for this hypocalcemia, we give calcitriol, a form of vitamin D3. So that's a lot to memorize, but you have to understand it, memorize it, lock it in so that no matter what they ask you on the NCLEX, you've got this. So let's review it. Chronic kidney disease, they're going to be tired. And what does that mean? They're going to be tired. You're going to have to give them more time to do activities. When you're teaching them, you're going to have to do it in small increments. You can't give them a whole 1 hour lecture on how to live with chronic kidney disease. They're tired. You're going to have to do 5 to 10 minutes here. Ask them a question to make sure they understood. Give them a break and come back later, right? Give them rest periods because they're fatigued. Why? Because they're anemic. Why are they anemic? Because they don't make enough erythropoietin. What is the treatment? We give them erythropoietin. What is it called? Epoietin, darbepoietin. Give them iron. Give them blood transfusions if needed. They're at risk for GI bleeds. What medication should they avoid? NSAIDs. What are the top 3 NSAIDs to know for NCLEX? Aspirin, ibuprofen, and naproxen. Why? They burden the kidneys and they increase the risk for GI bleeds. Then we talked about high potassium. Why? The kidneys can't get rid of the potassium the way that it should, right? So what kind of diet? They need to be on a low potassium diet. What are some meds that we learned that can drop the potassium? Polystyrene sulfonate, Kxalate, regular insulin and dextrose, and loop diuretics, right? High magnesium. So they need to avoid medications that have magnesium in them, like milk of magnesia, magnesium citrate, okay? And keeping in mind, if we give them loop diuretics will help drop that magnesium level. High phosphorus, so we're going to give them sevelamer, Renvela, okay? And because the phosphorus is high, the calcium is going to drop. What medication are we going to give them for the low calcium? Calcitriol. So you have to memorize it. There's no way around it. Some other issues they're going to deal with, hypertension. So we're going to plan on preparing medications that will help them. Why would they have high blood pressure? Remember, the kidneys are two filters. Their filters aren't working, so all their fluid volume stays inside. And the more fluid that stays in your body, the harder your heart has to work to pump it all around, to circulate it. So that causes high blood pressure. So we give a mix of, diuretics can help drop the blood pressure because they reduce fluid volume, but mainly antihypertensives are going to help these patients. Okay? So remember, this is recorded. You're going to have to go through this again. All right, some other issues that they're going to deal with, uremic frost. Uremic frost is because of uric acid crystals that usually would leave the body. These chemical components would usually leave the body through the urine, but because the kidneys aren't working well, they have to find other ways to leave the body, and so they leave through the skin. And when the sweat evaporates off the skin, you're left with this uremic frost. So this could be very depressing for the patient to look like this, especially the first picture. That looks like a young gentleman, right? So you can understand how patients with chronic kidney disease often have depression and are at increased risk for suicide because a lot happens to their body. It even affects their sexual health. They often have reduced fertility and they often have fertility issues. Men often have issues with their sexual performance. Women often have irregular periods. So men and women affected with chronic kidney disease, they often have depression as a result of the change in their appearance. Chronic kidney disease can even have an odor on their breath. The uremic frost, their skin becomes itchy because of the crystals leaving through the evaporation. Then you have all the issues they have. Then you have that they need an AV fistula or AV graft, and that they have to do dialysis 3 days a week. And how are they going to get there? And what if they have kids and a job and this and that and a career? What if their dream was to become a nurse and now they need dialysis? Or a kidney transplant, and they have to wait on a kidney transplant list for 5 years. Some people never get it, right? Chronic kidney disease is a terrible condition. And if there's a way we can prevent it, we should do it. So it starts with your patient has high blood pressure. Let's educate them on the lifestyle changes to not get there. Have you had your blood pressure checked this year? It's important that we educate ourselves, our family members, our friends, our loved ones, our neighbor, our co-worker who keeps doing 3 doubles back to back, right? For what? For a place that would fire you and replace you in an hour? Hypertension leads to chronic kidney disease, it leads to stroke, it leads to heart disease, and it leads to death. Take care of yourself. Make sure you have your blood pressure checked. Go to your annual health visit. Get checked out by the doctor so the doctor can check your blood pressure, so the doctor can check your urine level and make sure you don't have high amounts of protein in your urine, which would indicate that the kidneys are in trouble. Get your blood work checked. When you go to your annual wellness visit, the doctor will check your blood levels to see if your kidneys are okay. So that if you have prehypertension, the doctor can begin monitoring you. But if we're just walking around living our lives, never checking our blood pressure, never taking care of our health, never eating right, never wanting to go for a walk, you know what happens? That's when people just say, oh, I have a headache, and then they never wake up. Don't do it. Educate yourself. Eat right. You know what to eat. And you know what to drink. The only liquid your body needs after breast milk when you are a baby, after that, all you need is water. Soda, coffee, juice, all that sugar, it's causing diabetes and it's causing high blood pressure. Eat right, drink right, go for a walk. Why can't you? Why don't you just, I know you're studying for NCLEX, but why can't you go for a walk? 15 minutes. And if your life is so busy that you cannot go for a 15-minute walk, well, because you've got the kids, take the kids with you. You want them to start early, right? If your life is so busy that you can't fit a 15-minute walk every day, I'm not speaking this over your life, but you need to rearrange your life so that you don't end up with a disease. Okay? I always take my time when I get to cardiac and when I get to renal because it's not worth it. I know so many women who had high blood pressure and didn't take care of it. My own aunt had high blood pressure and she never wanted to take her medication. One day she went to take a bath. She fell on the floor in the bathroom and from there, never spoke again. And she died in the ICU. Well, she was in the ICU for 3 months with a trach, couldn't talk, couldn't eat. And then they sent her home and she died. take care of yourself. I always make this so serious because you usually are the first person who can have the opportunity to educate someone outside of the hospital. Not a lot of people have insurance. So you know this knowledge now. So you can go educate your neighbor, let's say, who they say, I've been having a headache every day this week, no matter what I do. Well, are you drinking water? I never have time to drink water. Well, are you sleeping enough? Oh man, I'm doing three doubles back to back. I've been sleeping like 2 hours a day for the past week. And you're like, well, that lifestyle is not good for you. You need to drink water so your kidneys can properly get hydrated. When you're not drinking enough water, your kidneys aren't getting enough oxygen. And that's how the kidneys begin to die. And that's what leads to acute kidney injury. And you tell them you need to drink water. You need to get enough sleep. Well, I have to do that and I have to do that. Well, what can you fix in your schedule? Because you have to sleep. Just like a car needs gas, you need to sleep. Just like your phone needs charge. If you leave your phone off the charger for 3 days, can you pick it up and use it to make a phone call? No. You need sleep, right? Because everything is interconnected. When you're not getting enough sleep and your body is constantly under stress, your body is releasing those stress hormones, cortisol, which increases your blood sugar, which what can lead to diabetes, right? And cortisol is associated with obesity, which can be a catalyst for heart disease, the number one cause of death. Heart disease can lead to kidney disease. Kidney disease can lead to heart disease. It's all tied together. Also, when you're under a lot of stress, your body is releasing epinephrine, norepinephrine. What is those other names? Adrenaline, noradrenaline, right? Because of the sympathetic nervous system. And what do? Adrenaline and noradrenaline, they increase your blood pressure. They increase your heart rate. They increase your blood sugar. So in increasing your blood pressure, you're further damaging the kidneys. So you now have this information, and I want you to use it for you. I want you to use it for those you love. I want you to use it for those in your community. And I want you to use it for the NCLEX so you can get your nursing license and you can help other people. Okay? All right. So let's take a 2-minute break. And when we come back, we're going to begin talking about hemodialysis. Class is going to end early today. We're going to end around 12 because unfortunately I do have an appointment that I could not cancel. However, we're making very good progress. And so what we'll do is I'll introduce you to hemodialysis, and then we'll close off with a couple of questions. And then I'll give you some homework because renal is a lot. And the more time you dedicate to understanding it, the better you will do on the NCLEX. Okay? I'll see you in 2 minutes. All right, guys. So I want to introduce you to dialysis, okay? So there's two forms of dialysis. There's hemodialysis and there's peritoneal dialysis. So hemodialysis is using the blood, right? And so we're removing the blood from the patient's body and passing it through a dialyzer, which is a machine, and it's going to perform the function of the kidneys and filter out the waste from the blood and then put the clean blood back in the patient, right? And so Then there's peritoneal dialysis where we're using fluid, we put fluid in the abdomen, and the wastes from the body are going to diffuse into the fluid. And then when we drain the fluid out, um, we're removing the waste from the body that way. So each method of dialysis has a pro and a con, right? For example, hemodialysis with the blood, you have to get it done, 3 days a week, right? Peritoneal dialysis, the schedule depends. Hemodialysis, you have to go to a center to get it done. So, someone, if the patient can get dressed by themselves, okay, but maybe they can't. So the caregiver has to get the patient ready. Then they need transportation. Then they're going to be sitting there for 4 hours, 5 hours, right? 3 days a week. And then they need transportation back home. Remember, patients with CKD are already exhausted and fatigued, and some of the medications they might get might give them diarrhea. So it's a lot, right? Versus peritoneal dialysis, you get to do it from home. However, peritoneal dialysis, because you're doing it from home and because of where they're accessing, there's an increased risk for infection. Peritonitis is the number one complication of peritoneal dialysis, and peritonitis can be deadly. And then there's hemodialysis. You need some type of access for it, right? And so it has to be surgically created, and the AV fistula and grafts can be very big in the arm. They can look like a snake under the arm, so it's very big. And again, it can add to the grieving process they have over loss of body image, right? So let me show you what an AV graft, can look like. It can be very big. Look, it can look just like a, do you see that picture? It can look just like that. I've seen some look like that. I've seen some look a little smaller, okay? Um, but it can look just like that. So you can imagine, like, if the patient has the uremic frost and they are having issues with sex, and they have this, and they have to do dialysis 3 days a week for 4 or 5 hours, and they have financial issues affording their medications, and so it's a lot on the patient, right? So again, I know I keep repeating myself, but that's why I never want a patient to have to get to this point, because if there was something we could have done, like control their blood pressure or control their blood sugar if it was because of diabetes, let's prevent it from ever getting here, right? Or here. So for homework, I want you to read the rest of Module 6. So starting from page 205, read on dialysis, peritoneal dialysis, and read your renal meds. So in short, make sure you've read all of this section. It starts on page 200. So just look at the top of the study guide to show you. And I know this says 205, but go to page 200 to start. So read it, and that will help you to prepare for next class where we will finish renal. So now let's close out with 2 questions on what we just learned. Okay. Question 37. A client is to receive, oh, well, you know what? We're not going to do that one yet because we're not going to do 37 yet. We'll do that next class. But 38. A client has been admitted with acute renal failure. What should the nurse do? Select all that apply. So take a minute or so and put your answers in the chat and then we'll go over it. This is a tricky one, but we're doing question 38. Okay, the correct answers are 1, 2, 3, and 4. So we want to elevate the head of the bed 30 to 45 degrees. So this is like, it's like a tricky one and it's not a big deal, but basically they're saying like the kidneys aren't working. So all like if the kidneys aren't working, fluid volume is not going to leave the way that it should. So all the fluid volume is going to stay inside. And remember, the more fluid volume there is, the harder the heart has to work to circulate it. So like the more fluid volume can lead to like shortness of breath kind of thing. And so that's why we want to elevate the head of the bed. We want to take the vital signs, especially like so we can start to see like what could be the cause of the acute renal failure. Remember, acute renal failure, the onset is rapid, right? It's a rapid onset. So checking the vital signs, like for example, the blood pressure to see if the blood pressure is low, maybe they have acute renal failure because we need to give them fluids, and that will help to properly perfuse the kidneys, right? And reverse the tissue issues. Or is the blood pressure high and we need to give them antihypertensives? Do they have a fever? And could that fever point us to, okay, let's collect the urine and do a urinalysis, and oh, they have white blood cells, maybe they have a UTI. A UTI could lead to acute renal failure if it's severe or has been untreated for some time. So we want to take the vital signs to establish our baseline vitals and to start to point us in the direction of what could have caused the acute renal failure. We need to establish an IV access site to potentially give medications that could help, to give IV fluids, and then call the admitting physician for orders. That is standard. And then we don't need to contact the hemodialysis unit because this is acute renal failure, not chronic kidney disease. Okay, 39. Which of the following is the most common initial manifestation of acute renal failure? Put your answers in the chat. Number 39. Which of the following is the most common initial manifestation of acute renal failure? Mm-hmm. Very good. The correct answer for 39 is choice 4. So oliguria is definitely the most common first sign. The first sign that something's wrong with the kidneys is they stop working. And by stop working, they don't make enough urine, right? Very good. All right, now we're going to do, let's go to another, let's do some questions on chronic. Okay. 91. The client with chronic renal failure takes magnesium hydroxide, milk of magnesia, at home for constipation. The nurse suggests that the client switch to psyllium hydrophilic muciloid metamucil because we're on question 91. Mm, it's not that it's too harsh on the bowel, but what electrolyte imbalances is the patient at risk for with chronic kidney disease? Everything's high except calcium, right? So potassium is high, magnesium is high, phosphorus is high, calcium is low. So because magnesium is already naturally going to be high for them, we don't want them to take magnesium hydroxide. Okay, so the correct answer for 91 is 1, okay, because it can lead to magnesium intoxication. 93, we're going to skip to 93. Well, actually, yeah, we'll do 93 and then, yeah, we'll do 92 next class. 93, the nurse is instructing the client with chronic renal failure to maintain adequate nutritional intake. Which of the following diets would be most appropriate? Mm-hmm. Very good. So for chronic kidney disease patient, low protein, very good because they already struggle with removing with issues with protein, right? Protein is very hard on the kidneys. Um, and so therefore a low protein diet, very good. Low sodium because we don't want them to retain more fluid. They're already having issues removing fluid from the body. And low potassium because they struggle with high potassium levels. So very, very good. All right, guys. So please, 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 your homework is to make sure you've read all of the renal section, which starts on page 200 in your study guide. Review this recording. Make sure you add on to your notes and you review your notes. And then when we meet next Friday, same time, same place, we will finish up renal. All right, you guys did excellent today. Thank you so much. God bless you. And I know that you all will become successful nurses. God bless you. Thank you.